The opera studies have been, I think, hugely beneficial for the orofacial pain world. We've got such a wealth of great data that the opera studies are making available to us. And you and Dr. Svensson offered a critique about a potential confounder of the relationships among these chronic pain conditions that we so often see as being comorbid with orofacial pains. And it has to do with sustained medication use. Can you talk a little bit about that?
Yeah. So basically, Peter and I were asked to make a commentary on 3 of the papers. And like you said, I think the opera studies have given us a lot of different, a lot of knowledge and a lot of even different, not only things that changed a little bit the way that we look at things, but also, at least for me, inspiration on different types of research that can be done in the future and so on. But we were looking at it and saying, well, what exactly maybe could be causing us to see all of these overlapping pain conditions in one individual? And one of the things that came in mind was medication overuse, because at least in headache studies, and that's kind of a lot of also what my research is also involving a headache. If we don't take into account how much medication a patient is taking, that's a very difficult study to publish, because they'll say that you have not taken into account medication overuse headache. So it becomes very difficult for you to have a study on migraine or tension type headache without saying we excluded patients that were taking so-and-so that fulfilled criteria for medication overuse headache, or at least that you put it as a confounder of some sort in whatever study that you're doing. And in that case, they actually hadn't done that. So that, together with the fact that there are quite a few studies that show that if you take opioids or analgesics, in this case it seems like it's opioids more than analgesics, but like ibuprofen and so on, but they both do the same thing, that you are more likely to have increased pain sensitivity after a while than if you don't. And if we look at the way kind of things follow, if you have, say, TMD, and you start taking medication every day, and it starts lowering your pain threshold, so it increases your pain sensitivity, and then maybe something else happens, nothing tells me that you're not likely to get headache or fibromyalgia or low back pain or whatever it is because of that, and not necessarily because of the TMD, or even in conjunction with the central sensitization that occurs from the TMD that also lowers those pain thresholds. So I think it is something that we need to be aware of, is that it may not be such a straight relationship between I have TMD, and because of that, I have a higher risk of getting these. Yes, it could be true, but we need to be aware that maybe there's kind of like an intermediary in there, which could be excessive medication use. A little bit like the way I look at, for example, TMD, bruxism, TMD, and headache. There's a lot of studies that confound those two, and it seems like there's a lot of studies that think bruxism can lead to headaches, but for the most part, with the studies that I've read and kind of clinical my experience, it to me is more like maybe bruxism can lead in some patients to TMD, and then maybe that, if it becomes chronic, then can increase the chances of you getting it. But it doesn't seem like there's necessarily a direct relationship. So I look at that kind of in that same way, is that it could be an either or kind of thing. Either and, sorry.
It never seems like there's a simple answer, right, to all these questions. So that's really a fascinating thought for sure. In the same paper, you also noted, and I'm quoting, that there's a need for mechanistic studies in order to advance the understanding of the underlying neurobiological mechanism in chronic orofacial pain conditions. What kind of studies might help us gain that understanding?
So I think at the end of the day, it's a little bit like Rafael Benoliel also wrote a commentary on the studies, and he kind of said that there are two types of people, right? There's the splitters and there's the lumpers. For the most part, I think that we're a little bit splitters in our lab, because we feel like it is important to understand, once you've kind of lumped patients into myalgia, neuropathic pain, this and that and the other, that within those patients, that there are probably different types of patients. So there may be, for example, say that you have a patient that has TMD. There may be one patient that has a deficient endogenous pain system. There may be another patient maybe that has some kind of autonomic dysregulation. Maybe there's another patient that the big part of it is more related to facilitation of the central nervous system and so on and so forth. And the way we do that in our studies is, for example, again, we assess endogenous pain modulation through CPM. We do quantitative sensory testing. We do normally the German Research Network protocol. We can do functional imaging. So there's all of these kinds of things that can be done. Now, the problem, I would say, and these are all things that we are trying to improve also, is that when you try and understand, because there's a theory that says that, for example, if you have a deficient endogenous pain system and you have chronic pain, then all you need to do is give that patient something that boosts that endogenous pain system, and they'll probably get better. And the same can be said for example, neuropathic pain patients that have ectopic firing of sodium channels and things like that. And that can be assessed in a correlate kind of way through quantitative sensory testing. And if you give those patients something towards that, then they should get better. The problem is that there's at least one review that I know of that has taken a systematic review that has taken all of those results, and it doesn't really seem like we are getting there. So it doesn't seem like there's a big difference between assessing those patients in that way and saying this patient needs this treatment, and then you give them that treatment and they get better. So I think the problem with that is that we're not driving our kind of splitting in the way that we should. And I think we need to be a little bit more aggressive in that splitting, in the sense that, for example, when we do conditioned pain modulation, we only assess that once for the most part. And there are studies that have shown that if you assess them 2, 3, 4, 5 different times, you are able to double or triply split patients into some that have a little bit more endogenous pain modulation, others that have a little bit less endogenous pain, and so on and so forth. So maybe we need to kind of push the individual system a little bit more to actually get the results that we need. But at the moment, this is kind of what we have, and that's what we work with. And I think for the most part, it seems to be able to define the patients, but I think we're missing that next step in defining what maybe is the problem with the patient to the medication or whatever the intervention is actually helping them. So I think that's kind of the step forward. Maybe if you ask the lumpers, they'll kind of say, well, that's why you're wrong, is because we need to take a more general overview and kind of look at all patients in the same way. But I don't think I can understand that for research. Maybe that works, but I also do clinic, and I could never look at a myalgia patient and neuropathic pain patient in the same way. So there has to be maybe a combination of the two in a way, and also in terms of research and clinic, I think for us to get the results that we want.
And that sounds to me a little bit like personalized medicine, right? Or precision medicine, which is this term that we kind of all tend to try to reach out. So,
yeah, I think that would be ideally what we'd want, right? So you'd want somebody to say that would be very easy if you measure their endogenous pain system through conditioned pain modulation. You say, well, look, this is deficient. Here you go, take some duloxetine that kind of boosts that endogenous pain system, the serotonin, norepinephrine, and so on, and you'll get better. But unfortunately, the studies that we have show that things aren't that easy. And aren't that easy because maybe we're wrong, or they're not easy because there's an access to component, of course, that medications don't take care of necessarily. We don't know. But yeah, that would be the goal. But when was it? Maybe a year ago, Luda Diachenko was at Aarhus, and she was doing was explaining that they kind of do the same thing right now, or they're trying to do with genetics and precision medicine the same thing that they're doing, that they did for cancer. So cancer is actually, I think, a success story in the sense that they, through genetics, for example, through genotyping, they can say, okay, you're this way. If we give you this medication, we know that it's going to be better and your cancer is going to regress in a better way, and so on and so forth. But we haven't been able to do that with pain. So again, there are these success stories doing these things in other fields, but we seem to always be not getting quite there for some reason.